the patient who will undergo surgery for sexual transformation from female to male. This patient contact us because she wants to offer her uterus. He wants to donate her uterus that will be removed anyway. So this is a real case here for us too. A third one, a couple of doctors with infertility who want to have children. The woman has a Morris syndrome. So she's a XY and with a lack of male hormone receptors. She wants to do a uterus transplantation and embryo transfer through the eggs donation and the sperm from her husband. So this is just to look at the scenario that we are involved nowadays. This case described will increasingly appear in our transplant and infertility community. And the society nowadays currently value more the autonomy, individual autonomy in decision making. We are facing reducing prejudice and accepting more differences. All the information are available worldwide and accessible. We have a revolution in technology and shift in many paradigms. And what are the standard uterine transplant indications so far? So is the infertility with absolute uterine factor. For this, we have mostly uterine malformations in Mayer-Rokitansky-Hauser syndrome, previous hysterectomy because of neoplasia, hemorrhage, and intrauterine adhesions as Asherman syndrome. This counts for 15% of the population, and is 3 to 5% is because of uterine causes. Alternatives are surrogate, uterus, or adoption, but many couples doesn't have this option or doesn't want to adopt. And in some countries, the surrogacy is prohibited or restricted, as Japan or Sweden, for example. The history of transplant in 60s started with the first experimental models in sheep. And the next model was carried out in dogs in the 1966. The first successful report using vascular anastomosis. In conclusion, they concluded that would be feasible, a transplant would be feasible after that. The model using sheep, it's a very good model for technical preparation, technical practice. The limitation is it's easier. The pelvic anatomy of the sheep are easier to dissect, easier to do the anastomosis than humans. This was the first reports in Saudi Arabia with a living donor in 2000, and it was reported a graft thrombosis. And in Turkey in 2013, with a deceased donor transplant, and have problems to get pregnant, this woman. After that, this was the first successful series from Sweden, and they transplant 9 cases, and they lost 2 grafts, one because of thrombosis and another because of infection. So this was the first report, birth The recipient had 35 years old with Rokitansky syndrome. It was a living donor. And we performed the first case of a successful first case of deceased donor. This was in our university here in São Paulo. Recipient with 32 years old, also with a Rokitansky syndrome. The donor had 45 years old, and the cause of death was a brain hemorrhage. And the donor had already 3 deliveries. The pregnancy was 7 months after the transplant, and the delivery by cesarean section in the week 36. Since then, since the beginning, the number of publications and the interest has grown around the world. Many countries started their program and started doing transplants. In our last meeting in the United States, in Birmingham, joining the register from US and the rest of the world, we have around 110 transplants done and more than 60 births. And so it's a very good result, and the numbers are increasing, and we hope that more countries and more centers start to doing this transplant, then we get more experience with the transplant. And also, some centers started to use the robotic platform to do the donor, and also some of them are using in the recipient as well. So this is very interesting. Here we didn't do yet any case with robot, but it's very attractive and interesting for live donors. Here we can see this is the publish of the register. We have a number with laparotomy, but it's increasing the number of donors doing robotically. We have already the births coming from the donors that perform robotically the surgery. Then, before starting the clinical program, the clinical transplant, is very important to perform some experimental procedures, I think, in order to become more aware of the anatomy, pelvic anatomy, and the anastomosis, the training. Here, we used a lot of the sheep model that is easily reproduced in many centers, and it's a very good training, technical training before the uterus program transplant. I can show you in our facility here the difference of the uterus. The uterus have a big cornus, uterus anatomy, and we can dissect the external iliac vessels, artery and vein, and after the removal, we can isolate the ureter and the uterine vein and the uterine artery, remove the uterus, prepare in a bench procedure, well prepare the artery with a good patch from the internal iliac artery. And this, you can see the anastomosis of the vein and the artery, and after the reperfusion. Here we have a small video. We were studying the difference between the reperfusion, the concomitant reperfusion versus the sequential reperfusion. In these cases, if we have any difference comparing this two. So here you can see we anastomose the artery and the vein in the external iliacal vessels, and we are comparing those two ways to, and it didn't show any difference between those two forms of perfusion. It's very important also, as we don't have many cases and centers very experienced in this procedure. We have a series, each center have a few numbers, so it's very important to share our experience, share our results, to learn from another centers, to learn from other cases that they had problems. So this is very important to contact. We've been in Sweden and also in contact with centers in North America, and this is, I think, is very important. And the procurement in the beginning was very difficult in cases of deceased donors. It's the pelv anatomy. It's narrow. You have a lot of fat and grass. So after perfusion with preservation solution, it's very difficult to identify these structures, the vessels, and we'll try to remove with the internal iliac vessels and also with the ovarian vessels and the vaginal stump, all the ligaments, and we remove the ovarian and we take the ovarian out after. It's easier to take it out after. But this procedure is not so easy. Sometimes when the patient, the donor, is a little bit fat, it's more difficult. And so we have to train to do some cases. This was our first cases of procurement we did. We did 13 in the beginning, and we used those two, the 7 and 9, and was the average age. These more old women, we performed the procurement just for training, just for doing the procedure, and so we standardize how to cannulate the solution. We did it differently from the centers in the US. We cannulate separately the iliac arteries, both two sides, and we clamp the femoral arteries. So with this, we have like a localized perfusion in the uterus, and we use ATK, that is a less viscous solution, and we perfuse with a pressure the organ, because it's a muscle organ. Sometimes it's more difficult to perfuse the uterus. So this was how we did it in the beginning. And the final aspect of the graft, we removed with all this grass and the vessels, and this is the vaginal stump. So it's in one of our procurements. This is Dr. Dunny, that is our gynecologist. He went with us in our procurements too. I'm a transplant surgeon, and those are fellows. One fellow from Colombia, Felipe, one fellow from Italy, and here Danielle, that's working with us. So many procurements we went. We performed 2 cases in the beginning, 2016, 2017. And the first case, I'm going to show you the profile of the donor. So the age was 45. I think it was not a limitation. Now we want to expand the donor age to 50. BMI 28. The parity was 3, so 3 deliveries. No cardiac arrest. ICU stay 2 days only, using vasopressors. No acidosis, and we use HTK and the cold ischemia time was 6 hours 25 minutes. This was the warm aspect with all the grass around, and the vaginal stump here. And the recipient profile was age 32, BMI 23, was good. Rokitansky syndrome, the indication, surgical time 660 minutes. Blood loss was quite high because we let a lot of vessels in the womb open, and after we were very worried about thrombosis, not about bleeding. The warm ischemia time was 1 hour 25, and the total ischemia time 7 hours 50. Long ischemia time because we were the last team allowed to remove the organ in the donor. The graft survived. We had no complication during the surgery, and the patient has a menstruation 35 days after the transplant. This was very good, and no rejection episodes. So pregnancy and childbirth. The time after transplant for embryo transfer was 7 months. We in the literature that time they were using like 1 after, but we thought that 6 months after was enough to transfer the embryo, but we let 1 month more because of the endometrium was not good enough, and we had no rejection episodes. This was the live birth was with 36 weeks, and the weight of the baby girl was 2 kilos 550 grams. The few complications during the pregnancy, only a urinary infection and also a respiratory infection, very mild. The indication for delivery was the fetal age. Hysterectomy, yes, and the child development was normal. This was few ultrasounds before, and the baby during the delivery, after the delivery. Second case, the profile. If you see the profile here, this case failed, but the profile was not bad. The age was younger than the first one, BMI good, the parity, one history, one delivery. But the patient had cardiac arrest minutes. This was the difference, and a longer ICU stay, 5 days, no pressures and acidosis. So the patient was not very well managed in as a donor, I can say that. The recipient profile was 27 years old, BMI 27, also Meyer-Rokitansky syndrome. The surgical time was 6 hours 50 minutes. Blood loss 500. Warm ischemia 2 hours. This long warm ischemia, maybe this can justify our failure. The total ischemia time 8 hours. It was similar than the other one, and we had in these cases vessel thrombosis in the second postoperative day, and we removed the uterus. The patient had no problems with that, and the wound healed, and she wanted to submit another transplant. She told us this. So the surgical technique was an infraumbilical laparotomy, a median. With anastomosis, we performed anastomosis with all the uterine veins, the foreign veins, and arteries. This is a figure showing the artery anastomosis. The uterus before revascularization and the uterus after reperfusion. We use as antibiotics piperacillin, tazobactam, and fluconazole, and this is ivermectin. It's our protocol here to use. And as we perform an induction for immunosuppression, we use also prophylactic ganciclovir, and then we continue with valganciclovir. And this is sulfamethoxazole trimethoprim as a prophylactic antibiotic for 6 months. The first menstruation, 35 days after transplant. We take the biopsies 1 week after the uterus transplantations, and we perform it regularly, weekly, for the first month. And after that, twice a month during the second month, and then once a month until the 20th week of pregnancy. This was the aspect of the vagina, was a good aspect. Luckily, we had no stenosis in the vagina, and so we could visualize. It was a little bit narrow, but okay to do the biopsies. The follow-up, psychological follow-up, was good. We followed with psychologists and social workers during this protocol in the pregnancy with no complications. We had this respiratory infection, that's viral etiology. It was okay. And the transfer, we intended to transfer the embryo 6 months later after the transplant, but we performed 1 month after. In other words, 7 months after transplantation and 19 days after menstruation. And the embryo was a B3AB in a natural cycle, supplemented with 400 milligrams of progesterone vaginally, starting 48 hours after ovulation. So this was the first HCG, was performed BET HCG 10 days after embryo transfer, and it was 203 and 4 weeks. We had this identified on ultrasound, and we did a non-invasive prenatal testing in 10 weeks after, showing normal female fetus. The pregnancy was very good and eventful, and we let the level of immunosuppression in the beginning around 8 to 10 in the first half of the pregnancy, and in the last half around 6, as we didn't see a rejection. So, as I said, we had no episodes of graft rejection, and that was confirmed with cervical biopsies. This was the only infection the patient had during the pregnancy. There was a urinary infection in the 32nd week that was treated with antibiotics without any other problem. And the delivery we performed in the 36th week with 35 and 3 days. This newborn girl weighed 2 kilos, 550 grams, and measured 45 centimeters. And it was a very standard delivery. She stayed with her mother in the same room, and they were both discharged 3 days after. The uterus was removed during the cesarean section. This was discussed before with the patient, and she wanted only one child. So we removed the uterus using the same incision, the same incision for the delivery. The uterus weight 900 grams 50, and showed a usual gestational change with no evidence of rejection. Only the arteries were thickened by intimal fibrosis, hyperplasia, but had no obliteration. And the placenta weighed 405 grams and showed no abnormalities. The mother and the baby had a follow-up without any incident. The wound of the mother healed well, no problem. And after after the delivery, we stopped the immunosuppression right away. And after 7 months of age, the baby continued breastfeeding and had normal growth parameters. So this is the baby, and she's doing very well so far. She is now 6. And I'd like to tell you and discuss, because I think everybody has problems with the program, and to begin, to start, we have many things to do. First of all, it was the ethical approval. After that, the deceased donor limitations, financial issues that we had and we still have, the COVID problem. This was a world pandemic problem, and there is still consideration of an experimental procedure. So the ethical approval, we did it. We discussed here in our institution, in our state, and after in our country, the ethical committee, the national ethical committee, and this was overcome. It took time and was overcome. Of course, here we have the problem of cost. Our country have many difficulties, and this was published. Mean cost, it has a time, but for Europe, for example, it's around 75,000-80,000 euros. For us, maybe it's less than that, but it still is a costly procedure. And the problem is sometimes the government doesn't consider like a life-saving transplant. So some people from the government doesn't want to invest on this because of that. For us, the first 2 cases was supposed to be covered by the government. They told us, the National Transplant System told us unofficially that they will pay for it. But in the end, it was paid by our institution, the University of São Paulo. Some of our bosses here they were not happy with that, because it was not supposed to be paid by the hospital, but in the end they covered, and we face difficulty to finance the next cases in our program. The problem of COVID here in Brazil, we went down with the donors during the COVID time, and here is the donors by million of the population. We were this was what supposed to reach in 2020 and 21, and the actual what happened here, we went down from 18 to 15 donors per million, and so this was the evolution, and now we are going back, increasing a little bit the donors per million. We stopped during the COVID time, so we had before that, few years before, couple of years before, we had problems of financing, and after the COVID, so we had to stop the program, and we restarted this year. We already prepared 1 patient to transplant, and she's in the waiting list. Maybe we are going to try to do a live donor here, but we didn't did it yet. It's organized to do in the beginning of the next year. So the problem of economic crisis here in Brazil and in institution, we had governmental problems, institutional problems, and let me come back. Also, to be paid by insurance and private, it's difficult because it's still considered experimental procedure. So it's not covered by insurance, or it's not allowed to be paid private by the patient. So it's only as a research procedure. We are trying to restart the program and to do more transplant with deceased donors. Here we have a problem of selection, female, of course, and mostly of the donors, they are male, they're not female. The quality of the donors, the family needs to donate the uterus. Sometimes they don't want to donate the uterus because of misinformation. The blood type, of course. So after all the selection, sometimes it's difficult to find a donor. And we are seeking for donors in our regional, in our the area of our city. So we are not looking far away because of the time of ischemia time and logistic procedures and everything. But if we look at the numbers, this is we are comparing liver transplant, for example. In US and Brazil, we increased a lot. If we look from 10 years ago, in 10 years, we increased the liver transplant 100%. So we increased the rate of donation, the rate of donors, and we had the 10 years before less than 10 donors per million per year, and now we are almost in 20. So we increased and the number of transplants too. So we have more deceased donors. So this is a good source. And also our state here in São Paulo is the state that does the most of the transplant in Brazil. So I think we have a good source of deceased donors here, and a potential to continue a program using deceased donors. The population of São Paulo is 45 million, and we have a good cooperation with our OPOs in São Paulo state. So we think that we have a good source of deceased donors here. For financing, we got recently authorized to do 2 more cases here in our institution, covered by our own hospital. We are going to try using the example of Europe, starting in Germany, for example, they got paid by the insurance, and US that they are allowed to do it commercially, trying to convince our institutions here that the procedure is not experimental anymore, and you can grow in numbers. And for our financing problems, we found a non-governmental organization. This we can receive donations from companies, private companies, and trying to finance for the patients that don't have money to pay. This is our non-profit organization. The name is More Transplant Institute. This is not only for uterus, it's for other transplants too, but we can receive or try to receive money from private companies to finance the transplant. And also to accept the procedure as a therapeutic procedure and not experimental, I think we need a stronger data. As we have only few cases each center, we need the world data, world numbers. And this can be joined by our societies, the international societies, the user societies, and also by the centers that are well-organized in the United States together, so we can show the world, show the institutions that we have good results, acceptable rate of complications. And here we are working with our Brazilian Transplant Society. The name is ABTO, and we create a committee inside this society, Brazilian Transplant Society, a committee of reproductive organ transplants that we aim to give the information for our community, not only health community, but the population also, so we can give this information and education about uterus transplant and publish inside this society that's well-recognized society in Brazil, the standards and requirements to do this transplant. I think this is very important, and we did it last year. We are now we have a committee inside this society, transplant organ society in Brazil. So I think it's the time to change it from clinical trial to a treatment option. This is a question, but I think the answer is yes. And with this, we can increase the access and number of cases and diminish the financing problems, the financing issues. In conclusion, the uterus transplantation remain an experimental procedure in many countries. Here in Brazil, for example, it has shown a good preliminary results in both transplant pregnancies and births around the world, with a good numbers now, more than 110 transplants, more than 60 births. It's expanding in transplant centers around the world. There is a big demand for uterus transplant and for many causes around the world, hysterectomies, malformations, etc. And this is a joint work between transplant groups and human reproduction groups, centers. So I can thank you very much for your kind attention, and I'm open, and I'm very happy and glad to be invited to contact you. It's my first time in contact with Saudi Arabia, and I'm very happy about it. Thank you so much.
Thank you very much, Dr. Andraos. Dr. Nora, are you available? Dr. Nora, she told me that she will be in the operating room for almost 45 minutes or 1 hour, and she may join us later. But
okay.
Well, it is very, very obvious that the Brazilian centers, they started already. I'm aware that in Sweden and United States, and recently I'm aware that in India, they have such a procedure. And you mentioned that you have successful story. And also you mentioned that it is still an experimental procedure and it is growing. So what do you think, where is the cutoff point? Where is the landmark to overcome labeling them as experimental to be therapeutic option? Do you think it is coming in 1 year, 2 years, or is there any volume that you think after that it is not going to be experimental anymore? What is your advice?
Yeah, I think with the numbers around the world that are showing very good results, I think this is already an information that can say that the procedure is not experimental anymore. But for a specific center, I think as the beginning, it's very difficult to start with many cases. You have to start with few cases. I think it's very important to do organize a multi-specialty team, do experimental procedures, and a link with another center that is more experienced to have a good result in the beginning. This good result in the beginning, I think, is very, very important. It's essential for the program and to maintain and to be sustainable in a long term. But I doubt that centers in the world, there is going to be many centers with a huge number of transplants. This is very difficult. But I think with these measures, we can start a good program with some cases, like doing 5 cases, 3 to 5 cases a year. This is going to be a good number of transplants.
I think I have a question from Dr. Nasser and Dr. Lisa. Dr. Nasser, please.
Thank you for sharing your presentation. But I think what's going on in Brazil, that they are not very good in publication, but they are good in working more. Like Saudi Arabia, they do more cases, but we never publish it. And I can see that from your data. I would like to just add extra point. If you think there is a success, this program is successful because it's easy. It's like 3-year or 4-year harvesting an organ, uterus, and then making a baby, then removing the uterus with the baby. At the beginning of the cases, we have difficult time to keep the uterus. Now with years, we manage to have cases. So if you have more than 90% of your cases succeed to deliver a normal baby, I think you have you have a success. So from the data I saw, I assume that you deliver how many babies so far, and how many times you didn't deliver. I'm sure that you are above the 90%. Just if you can comment on the number.
Yeah, we had only those 2 cases because of all the problems in the beginning because of the financing problems, and secondly because of the COVID. So we are restarting our program this year. We got authorized to do more 2 cases, and maybe with this non-profit organization that we are trying to get money from companies, I think we have next year we're gonna do more transplants. But I can't say that as our results with only those cases are very successful program. I can say that we have a program that we can do the transplant, but the results is very difficult to say that the results with only those cases. But I think looking at the world experience, and as we can see all the procedures, how the people do, and analyzing this, I think not only our center, but centers that have experience with transplant can manage this reproduction, infertility. I think it seems that all those centers can have a good result. Not only us, not only those centers that are doing right now, but centers that are well prepared. I think they can have a good result. Yes, Lisa, please.
Hi, thank you, Andres, for a great talk. Thank you so much. So I just wanted to comment a little bit on the clinical and experimental outcomes. I am from Baylor in Dallas, US, yes. And we have done 27 cases now. We actually stopped being experimental after 20 cases. So the first 20 cases we did was part of an experimental trial that was funded by the institution. At that time, when we had 20 cases done, we felt that we were, as a team, strong enough to move out of the experimental phase. And that is also true for one of the other American centers, Alabama, where they didn't start as an experimental trial. They had a surgeon that came from another center and had been doing this before. So they didn't start as experimental, they started immediately as a clinical program. So I think we are at various stages around the world regarding the experimental and the clinical phase. But I do think, as you said, that if you start a new program, you are going to have to do that under a review board or a experimental and partner up with a more experienced team. I think that's very, very important to get the good outcomes in the beginning. That was not a question, just a comment.
Thank you.
Thank you very much. Any comments or question from the audience? Participants, please.
I think there is a question saying why you do hysterectomy. Maybe you want to answer him after the transplant.
Why we performed the hysterectomy? Because we wanted to stop right away the immunosuppression, and the mother wanted to do a breast feeding for the baby. So we, I think if the mother wants only one child, and we don't have to do another operation for the hysterectomy, I think the hysterectomy during the delivery is a good alternative, it's a good option, and you can stop right away the immunosuppression and shorten the immunosuppression. So we had a time of immunosuppression of only 1.5 years, only 18 months. This was so good for the woman, the mother. So I think this is an advantage. But if the woman wants another child, I think it's already showed that it's possible to keep and as the baby was a healthy baby, was born with a very good standards. So I think that the hysterectomy during the delivery was a good option for her.
I will ask the same question I asked yesterday. In nephrologist, the renal transplant, the nephrologist will take care of the team. In hepatology and liver transplant, hepatology will take care of the team. Now, in your institute, who will take care of the 2 years of this patient?
Yeah, we are digestive organ transplanter surgeons, but we were working together with the gynecologists. So, but the patient stayed in our OR with us in the transplant OR, and not regarding
regarding the immunosuppression, regarding the medication.
We take care of it, the surgeons.
Oh, that's a great initiative.
It's different, yeah. It's even here in Brazil, for for example, in the heart transplant, it's the clinicians, they take care of it, the immunosuppression and everything. But for liver, it's different. I don't know why. I really don't know why. Here for liver, I think in US it's the same. They in the United States, they take care of the immunosuppression and the management, the clinical management of the patients.
I assume when there is a billing or money, usually the surgeon will agree to take care. If there is no billing, then they will defer it to somebody else. It's an observation, not accurate, I say.
Okay.
It's everywhere.
It's everywhere.
Thank you very much, Dr. Andraus. It's really to be in touch with you. It's very nice to be in touch with Brazil. Maybe one day we'll be there with our colleagues to have your experience. And thank you very much being with us today. It's really a pleasure. Dr. Rubalcaba, are you available?
Yes, I'm here. Thank you so much.
Oh, how are you, doctor? Nice to meet you.
Nice to meet you from Guadalajara. Good morning from Mexico. Good afternoon in Saudi Arabia.
Good morning. We welcome all Dr. Lewis. He's the gynecologist, the obstetric and endoscopic gynecologist in Mexico, in Guadalajara. Is that right? I'm sorry.
Guadalajara. It's difficult to pronounce. Guadalajara.
Guadalajara from Mexico. I'm really happy being with us today. we have Dr. Nasser Tawfiq. He's a senior anesthetist from King Abdulaziz Medical City in Riyadh. We have also Dr. Noura. I think she's in the OR right now, but she will join us soon. She is a member of the scientific board in the Saudi Commission Health Specialties for Obstetric Gynecologists. So thank you very much, Doctor. Please proceed with your presentation. I'll send you the host now.
Thank you so much. Let me put my first slide. First of all, I would like to thank the organizing committee. I am so proud to be in this symposium along with great speakers, Professor Dr. Wellington and Lisa Johansson. Lisa Johansson is working right now in Dallas in the best program in uterus transplantation. I am so proud to be here. As an introduction, I would like to say that I am no expert in uterus transplantation. However, we are working hard along with Mats Bryström. He is my very close friend since 2015. Nevertheless, we are working hard. We have had some different troubles in Mexico because from the beginning, we have problems to obtain the permit. And then, as you know, worldwide, the COVID affect us so much because we stopped, and we were trying to do it, our first case in 2019. And then we wait to do it, but one of our donor got COVID and we stop. That's why we are trying to do it next year. I organized this talk so simple because we publish in a well-recognized magazine in Brazil the story behind the first successful uterus transplant. And obviously our Mexican experience in uterus transplantation, but this is gonna be only in animal science because we are following the same steps that Mats Bryström performed. I met Mats Bryström in France in 2014. Thanks, Dr. Cesar Diaz. I met Cesar Diaz in St. Louis, Missouri, doing ovarian cortical transplant with Dr. Sherman Silver. And he introduced me with Mats Bryström. It was an amazing experience for me because staying in France, we agreed to do the first workshop in Guadalajara, Mexico. Guadalajara, Mexico is the second largest city in my country. And we are working, as I told you before, that so hard to obtain this an amazing achievement because if I can introduce myself, I am an infertility doctor, and I got the skills doing microsurgery, thanks to my friends. And we are following this procedure with Mats Bryström. In fact, he told me that he is going to be with us next year, along with Cesar Diaz, to obtain success in our two first cases. I think that the Mats Bryström got success because he went from the first idea that was in 1988 in Australia when he had a patient with cervical cancer. He decided to remove the uterus because obviously the cancer of the patient, this woman didn't have a pregnancy, and she told him that Mats, you must do a study, you must do all research to obtain the uterus transplantation. That was in 1988. But you can see here in this slide that he moved to the murine, to bovine, baboons, and then just before to do the uterus transplantation in humans, doing Bartine surgery in oncological patient. But there is no doubt that today all this kind of success is because we have in infertility patients right now a good pregnancy rate. That's why today all people think about the uterus transplantation, because obviously it's very important to perform the in vitro fertilization. But you can imagine when the first birth of the first test tube baby achieved by Bob Edwards and Patrick Steptoe, they have a low pregnancy rate, 5%, and in some cases they trying to find the egg, doing a chaotic procedure to obtain the first egg, and then to fertilize and obtain the 5% of pregnancy rate. Obviously, nobody think about the uterus transplantation, because as we know, the risk of the donor, the risk of the recipients. But today, there is no doubt that thanks in vitro fertilization, having a lot of strategies to obtain the pregnancy in a short time and avoid the side effects of the immunosuppression. But it's very important to mention this issue. Thanks fertility IVF. We have right now studies to understand if the endometrial is receptivity, if the patient has or not endometritis, and many diseases and many issues that we can observe. Today we have this term AUFI, absolute uterine factor infertility, in patient without uterus, obviously Rokitansky syndrome, previous hysterectomy by oncological patient for malignancy, leiomyomas, problems of the obstetrics problems, and also no function uterus, like a syndrome of Joseph Asherman, addition, radiation, leiomyoma, and malformations like uterus septus, Delphus, bicornuate, and unicornuate. There is also, we know that we have pros and cons, because for us, it still is a procedure, experimental procedure. And my apologies, because this slide is in Spanish, but we have here the pros and the cons. Obviously, the natural bonding between the mother and the child, the risks of the life quality of the mother, and the cons obviously is the risk of the surgery, the risk of the immunosuppression. But in this case, as we all know, obtaining pregnancy and then under the C-section, we can remove the uterus and we can stop the immunosuppression. What about the worldwide experience? There is more than 92 uterus transplantation, more than 49 newborn health. And you can see here the countries that obtain the uterus transplantation, most of them having the menstrual bleeding, and most of them having the goal, and the goal is to obtain a newborn health. Like Saudi Arabia, that you were the first one to do this each, to start this procedure. And then Turkey and Sweden, MATS obtained a great success in the first cases, nine cases, and then the Czech Republic, Germany, Brazil was an amazing this case of Dr. Wellington in a disease donor, and it deserves a mention of the Dallas duet with Giuliano Testa and Dr. Lisa Johansson. They are obtaining, they reduce the time to recover the uterus and to do the transplant, but and also to transfer the first single embryo transfer in blastocyst stage from the beginning. MATS 1 year after remove the mycophenolato, And today, we know that we can transfer the first blastocyst 3 months after we remove the mycophenolato. I think that people are growing fast in this field. As we all know, the first case was in 2000 by Dr. Wafa Fahi. He started, as I mentioned before, the itch to do the uterus transplantation. And obviously in 2000, we have had also a good pregnancy rate doing IVF. This is the first case. As we all know, everybody knows that the organ survival during 99 days and was removed because they have problems. And the second case, it's from Turkey. Dr. Özkan, an excellent plastic surgeon. You can imagine plastic surgeon. He is not a gynecologist, gyneco-oncologist, or infertility doctor, or surgeon plastic. He achieved this, he obtained a success doing this transplant, uterus transplant in a Rokitansky patient. However, the problem in this case is they obtained 2 pregnancies, miscarriage. The problem was the vagina was performed by intestine, and the microbiome, we know very well right now that microbiome is the role play is so important to obtain a good implantation rate and to avoid the miscarriage rate. And we believe that this is a problem. That's why in Mexico or probably worldwide, we must recommend when we perform the neovagina, must to be some different techniques and avoid the intestine. This is very important to mention. And what Matt's doing was to study in a murine model to obtain the knowledge and the skills to do the microsurgery and to know how works the immunosuppression. And so we all know that the same procedure, the same immunosuppression like kidney transplant, they repeat the same protocol. And in this model, they obtain good results, obtaining pregnancy in murine model. And then he moved to the bovine model. I am so proud that the Dr. Edwin Ramirez is part of our group in Guadalajara. He was born in Colombia, but he's working in California. And he obtained the first pregnancy in bovine model, the first calf. And he demonstrated that this is a good model to obtain the knowledge and obtain the skills to do this. That's why Mats Bryström moved as well to bovine model. And the preliminary human studies in part-time. As we all know, Mats is a gyneco-oncologist, and he did a lot of part-time surgeries to understand how we need to do to the lung of the pedicles, and he demonstrated that must to be around 6 to 10 centimeters. And then they went to Nairobi, Kenya, to work in a baboon model. We are following his steps, and we went as well to Nairobi, Kenya. In this Nairobi, Kenya, doing the uterus transplantation in non-primates, primates. This is the first trial. This is the first trial was the first 6 months, but this is the 1 year. We read this paper many times, and he demonstrated that he obtained the success because he take care. He went so slow, trying to understand the immunosuppression, the microsurgery, what to do also the blastocyst transfer, and he obtained from 7 out of 9 cases he got success, and all patients right now got pregnant. As I mentioned before, the first step is IVF. We are going to do the egg retrieval and then fertilization, and if possible, to do the PGTA to analyze the embryo and understand that these euploid embryos, because you can imagine if we transfer without this test, we can transfer an euploided embryo and we can have a miscarriage, or probably in some cases Down syndrome or something like that. Obviously, we need to do vitrification. As my background is, my group is pioneer worldwide doing vitrification, thanks to Masa Koyama from Japan. This is the best tool to preserve any kind of cells, in this case, blastocysts. And then we can perform as well endometrial to know how is the receptivity of the endometrial, the implantation window, EMA regarding all about the microbiota, analysis to understand if the endometrius has or not inflammation. And then perform the uterus transplantation as a second step, and remove the mycophenolato 6 months earlier. Today, some groups, they are removing the 3 months, and then performing the embryo transfer. And obviously, it's so important to do always set single embryo transfer, because you can imagine if we transfer 2 embryos and we obtain twins, we increases dramatically the risk in these cases in uterus transplantation. But also, it's so important to mention that the endometrial preparation, the most natural versus artificial, because we don't know if doing the artificial preparation, giving hormonal preparation, we avoid to present the corpus luteum. And corpus luteum play a role, important role in to avoid the preeclampsia. And as we all know, there are a lot of patients who have preeclampsia in uterus transplantation. The cornerstone, this is my point of view. I would like to ask Dr. Alisa Johansson if this biopsy, cervical biopsies, to identify these kind of changes in the tissue, we can find immediately if the patient started with a borderline reject, or reject grade 1, or reject 1-2, or reject 1-3, in order to modulate and to increase the corticoids, or to move the immunosuppression. I think that this is one of the best points to understand, to identify the subclinical rejection, to modulate or to change, to do some changes in the immunosuppression to avoid the rejection. And this is very important to give the tacrolimus, ácido mycophenolico, corticoids, and the first cases, the patient were at the hospital 5 to 7 days, and they performed an ultrasound, Doppler, and then started to do these biopsies to identify the spongiosis is the term, histological term, to understand if the patient started to rejection. It being very important to understand the lung of the pedicles. He published this information about the internal, external iliac distant 9 centimeters, and the long pedicles between 6 to 10 centimeters. And it's very important to understand that he obtained success, but we all know that the best problem or the big deal to do in this transplantation is the uterine vein. Some surgeons, some groups are trying to obtain the ovarian vein to do the drainage of the uterus, but obviously the perfusion is not the same. And this is a slide of Frank Netter. We know that we must do the microsurgery to put the uterine vein and uterine artery to the iliac extern. See? This is the first case. This slide, Mats allowed me to present these slides because they are so exciting. The patient as well, to demonstrate to the world that this procedure can be success. This is the first baby. This is the first couple. And then when they performed the uterus transplantation, that was in February 2013. And as you can see here in this slide, 1 year after the uterus transplantation, they performed the embryo transfer. And the patient have mild rejection, having 18 gestational weeks, and they performed the C-section at the 31 plus 5 days because she had preeclampsia. As you can see here, the donor was not relative, was a friend of the patient. And that show us that it's so important to select the donor, but it's not important that they must be relative. And here we can see the first uterus transplantation. This is a movie of the first uterus transplantation. Let me show you. And as I mentioned before, with completely permission of Mats Bryström. Let me put both together. I'm not sure, but I have problems to put together. But you can see the donor. Let me move a little bit fast because we can spend. Let me try if I can put. This is the first case. As I mentioned before, a patient who had cervical cancer. And you can see here the preparation of the recipient. Let me share first.
It's clear. It's clear. It's good.
It's clear. Thank you so much. Let me try to. At the same time, we can see the both videos. Let me try to put it. So sorry, I don't want to bother you, but this is the recovery of the uterus, the first case that was performed in Sweden, in Gothenburg. But an excellent surgeon, transplant surgeon, and Mats and Niklas Kavastron, Lisa Johansson, all teams in Sweden. They marvels the work doing this procedure, taking care and with great skills. No, este es. No, no quiero, quiero ponerlo al mismo tiempo. No se puede. So sorry. Let me put a little bit the transplant, the graft, the lung pedicles, the microsurgery. You can see here great ovaries that before the transplant, they performed the IVF. I can remember how many embryos they obtained. In that time, PGTA was not usual. Today is the best tool to transfer euploid embryos. And then they are opening the vagina and to do the uterus transplantation. So sorry, I cannot pass the video fast, but probably Lisa Johansson help us explain us these cases. What we are doing in Mexico, we started in 2015. As I mentioned before, I met Mats in France, in Paris, in 2014, just after I achieved the first pregnancy in a uterus transplantation. Cesar Diaz introduced me with him, and soon we talk about to do this workshop in a bovine model in Guadalajara, in my hometown, and we invited people from abroad, in fact, people from Latin America, from Argentina, Colombia, and all cities in Mexico, and we did some cases in bovine model. You can see here Cesar Diaz. You can see here Mats Bryson. He's so tall, I am so small. And you can see here Nicholas Cabastron, and an excellent. He has a lot of skills to do. He's a transplant surgeon, and he did. We did one cases. Obviously, it's so similar than in humans. It's we did at least 65 cases in Guadalajara just before the baboon model, and then we thanks our gynecologists, we are doing our time just before to do in uterus transplantation. That is going to be next year, probably at the middle of the next year. We are going to have Cesar Diaz, as I mentioned before, and as well probably Mats Bryson. For us, Mats Bryson, he's an amazing person, so smart, so clever, and he support us a lot. Why? Because he invited me in Gothenburg to organize the first International Society of Uterus Transplantation, and I told him, Mats, but we don't have experience doing in humans. But don't worry, Luis. You can give us your experience in animal model, in murines, bovines, and baboons as well, because we travel to the Nairobi, Kenya, to repeat the same steps that Mats Bryson did. We went in 2016. And then in baboon, that you can see here this paper of Lisa Johansson and Matt Bryson, that is a great model just before the Bartine surgeries. And then in humans, you can see uterus of baboon, and we did as well the same procedure with a back table using a special liquid like a custodiol. We have in Mexico custodiol, to do the perfusion of the arteries. Then we went to Gothenburg once again, 2016, to give our experience in Nairobi. We published in Fertility Sterility this paper, new modified surgical approach to obtain the pedicles. And as I mentioned before, the story behind the successful uterine transplantation in humans, along with Mats Bryson, he gave us all information, published this paper in a well-recognized Brazilian magazine. This is our team in Mexico. You can see here Edwin Ramirez is so well recognized in the world in bovine. He's from Colombia. He's our transplant surgeon, Juan Luis Contreras. He is doing a lot of kidney transplant, pancreatic transplant. Dr. Juan Carlos Canton, our gyneco-oncologist, I consider him probably the best of the best in Latin America, doing all about laparoscopic, in fact, in robotic as well, Edwin Ramirez. And my background, as I mentioned before, as a fertility doctor, and as well doing a little bit microsurgery that we learned with this specialist. He's doing a hand transplant. We are working here in a microsurgery in a murine model. And today in a cadaver, this cadaver is an amazing because the preparation of this cadaver is almost like you are operating a person who have a perfusion. And this is, I asked Mats to give us
hello, this is Professor Mats Brännström,
special message
Sweden.
to our president,
I started
to
research
our
on uterus
governor,
transplantation already in 1999. We worked in several animal models
all
for more
governors
than a decade,
and our
we
presidents to
were
allow
able
us
first clinical trial in
to do soon
2012.
the first
We
uterus
demonstrated
transplantation.
the feasibility of uterus transplantation as an infertility treatment by the first live birth in the world in 2014. During the years we did animal experimentation, we worked in close collaboration with Ed Ramirez, who is a pioneer in animal research of uterus transplantation. We worked together in the sheep model, both in Colombia and in Sweden. Since about 7 years, we have been collaborating with the team leader in Guadalajara, Professor Ruvalcaba. We've had joint seminars. We have done training in sheep in both Sweden and in Guadalajara, Mexico, and we have exchanged IDs. Our team in Sweden have done more than 30 procedures of uterus transplantation, the majority from live donors, both with laparotomy and robotic surgery. We have about 25 live births and several ongoing pregnancies. I endorse the project in Guadalajara, which has actually been done exactly as you should do, with preparations in animals and a slow process with a multidisciplinary team doing the first cases.
This video we present to our governor, we present to our president, and I was invited from the deputies of the Chamber of Deputies to present our experience, and they are going to support us to do soon this procedure. You can see here this slide, this photo comes from in 2016, then we organized the first International Society of Uterus Transplantation. This photo is so important because I have here a lot of friends from anywhere, any part of the world, from Japan, from Germany, Czech Republic, US, a lot of friends. Giuliano Testa and Lisa Johano deserves a great mention because I think that they are the best group in the world doing uterus transplantation. They have the most successful program because they reduce already the recovery of the uterus and the transplant and the time to do the embryo transfer. And this is my last slide. Thank you so much. As I mentioned before, I come from Guadalajara, Jalisco, Mexico, and I am so proud to born here in Guadalajara, in Mexico. And we guess that soon, next year, we are going to do the uterus transplantation in humans. Thank you so much, and I am open to discuss or to answer any question. Thank you so much. You are so kind.
Thank you very much, Professor Rubalcaba. It's really interesting to know different continents and different countries' experience. And I'm sure that sharing experience and making this international society for uterine transplant is a very good start. So the global doctors will be able to join and share experience and to know where to start. I'm not sure, is Dr. Noura available? Dr. Noura?
Assalamu alaikum. I just joined this minute, so but I recorded all the all the piece that I have missed.
طيب الله يحييك يا دكتورة. يعني دكتور Rubalcaba from Mexico, he presented his presentation and his their animal lab experience and their experience in Mexico. So if there is any specific question that you would like to ask him before we move to the last speaker.
I'm not sure, I'm sure that it has already been covered in the presentation, but in a nutshell, for somebody or a group who is starting, what would you say the best thing to do in the first one case?
Sorry, I can hear you well.
I'm saying I'm
Yes.
not. I couldn't attend the earlier. I mean the lecture.
No problem. No
like
problem.
in a summary, if like you are going to give advice to a group who is starting their first case, what are the
Okay.
1, 2, 3 do's and don'ts?
Yes, obviously, as I mentioned before, Max Bryson got success because he went slowly in an animal model. This is very important. Animal model is not. He wants that this procedure can repeat in the world, but in surgeons who have a good experience in animal model first. Probably in murine, then in sheep, then in baboons, and just before the uterus transplantation humans to perform the part-time surgery by gynecologists. This is very important because you can have good skills as a surgeon. However, if you don't have a great team, I mean, fertility doctors, because it's so important that the quality control in the IVF lab, we transfer a good blastocyst, euplot blastocyst. We must to measure the endometrial, that the endometrial don't have problems on the receptivity window and the inflammation and everything. This kind of doctor is an infertility doctor. And then as well, gynecologist and surgery transplant. Obviously, the surgery transplant knows so well the immunosuppression. That is very important. But my good advice is started in animal model. Max is 10 years to achieve this first uterus transplantation because he went slow, step by step in different models to understand the immunosuppression, to understand the microsurgery, but nothing new because he repeated the same kidney transplant protocol.
Right.
That is my advice, and we are following all that the Max recommend us.
Excellent advice. Thank you so much. Thank you.
Thank you so much.
Any question from the audience or participants? In the chat box, you can make your comment. There is one question, Professor, that in the question and answer, do you have in your group more than one pregnancy? If so, what was the outcome?
Sorry, I can hear you well.
Did you have in your group more than one pregnancy in each transplant? And if yes, what are the outcomes?
Yes, you mean in animal model, right?
No, I think the question that the speaker is asking about human, not animal.
No, sorry. As I mentioned before, we are going to do the first uterus transplantation humans next year. We have experience in animal model, and we obtain some pregnancies in a sheep model. Thanks, Edwin Ramirez. He is part of our group.
I see. Any other question from the audience before we move to the next speaker?
I have another question, if you allow me.
Yeah, go ahead.
Is the whole team, thank you so much. Doctor, is your whole team from the same city, or you have people coming over from other places?
Yes, most of them, we are living in Guadalajara. Only Edwin Ramirez come from California. He's a part of our team because, in fact, his father passed away a few months ago. He told his father that he trying to work hard to obtain this achievement, and he's working with us because in Mexico it's more easier to do this procedure. He's living in California, but he's coming with us in every workshop in a sheep model. In fact, he's going to be with us next month because we are trying, as I mentioned before, that to perform the uterus transplantation next year under umbrella of Mats and Cesar Diaz.
Thank you so much.
My pleasure.
Thank you very much, Professor Rubalcaba, and I'm sure that we will be in touch again.
Thank you.
Your work is marvelous, and we'll see you soon.
Thank you very much for your kind invitation.
Thank you. Our next speaker and the last one, Dr. Lisa Johansson. She's the medical director and uterus transplant in Simmons Transplant Institute in Texas, United States. You are welcome, Dr. Johansson. I'm aware that you did almost 27 successful uterine transplant already. So please proceed and go ahead.
Great. Thank you so much for having me today. It's a great honor to participate in this new interest of uterus transplant in Saudi Arabia. It's great. Can you see my slides?
Yes, go ahead.
Okay, excellent. So just to give you a little bit of background, and you heard some from the previous speaker. So I started working with uterus transplant with the Swedish team. That's where I'm from. I started in 2009. So I've been through all of these animal research, the first human trial over there. And then in 2016, I moved over to Dallas to start up the new transplant program here. So I've been in 2 programs. And both of them have been very successful. So that's a little bit of my background, and I will take you through today first of all, a little bit of introduction to uterus transplant, but then the outcomes of the field, especially in the US today, and what we've seen and what we have learned. So in terms of disclosures, I only have one NIH grant that I need to disclose for this talk. I should say that all of the pictures I'm sharing with you today is from uterus transplant babies or recipients or donors from the Dallas team. So you can see up on your right side, one of the babies that was born after uterus transplant, and on the lower right side, you see a couple of the recipients that we had with their babies afterwards that are born from uterus transplantation. We actually, in this group you see here, we have 1 Saudi Arabian patient as well from the Eastern Providence that moved over to Dallas to receive her uterus transplantation, and she has given birth to 1 child as of yet. She's going for a 2nd pregnancy right now. So I was at ASRM, which is the American Society of Reproductive Medicine, a couple of weeks ago, and some of you might have been there. So we were giving this workshop in uterus transplantation, and we had a poll question before the talk that said, should uterus transplant be presented as a way in which individuals with absolute uterine infertility can achieve parenthood? And in this very selected group of reproductive medicine doctors that really, this is their patients we're talking about, only 75% said yes in the beginning of the talk. This changed, I should say, after the talk was given, but we were interested in why did they say that? Why didn't all of them say yes? So a lot of the things that they brought up was the cost of the procedure, the benefits doesn't outweigh the risks in their minds, the immunosuppressive treatment, there's other options to retrieve form a family, and it's dangerous for the child. These were the concerns that was raised. And it all got down to that this very selected group didn't really know what uterus transplantation was. So I'm going to start this talk, actually. I know that you guys are probably very prepared and you know what uterus transplantation is, but my first slide is actually going to be a little bit of a basic knowledge about uterus transplant, because I think it's important that we all realize what this is. So first of all, it's a non-life-saving and a temporary transplant. So, and it's the only temporary transplant there is, really. So the organ is just meant to be with the recipient for the course of pregnancy and childbirth. And if that's one childbirth or two or three, that doesn't matter. But after that, it's going to be taken out. So to respond to the former question you had for the former talker, we have had several pregnancies and several deliveries in the same recipient, and they have all gone well. We have several that has given birth to 2 babies. We have one now that's going for her 3rd baby, but after that, we will probably take the uterus out. So the other thing is that the transplant is not for the direct benefit of the recipient's health. No one gets healthier, happier with the uterus. It's only meant for the childbirth. And that gives you the 3rd point as well. The purpose and success is not the transplant itself, and the only success is the birth of the healthy child. What is particular with uterus transplant is that the organ, the uterus, has actually exhausted its function for the donor. So if you use living donors, it's potentially easy to give away a uterus, more so than a kidney or a part of a liver, where you can potentially need the function down the line in your own life. When you're done with the uterus, it's a perfect organ to give away because you don't need it anymore. It doesn't have a function. The other thing that's particular is the stepwise success of uterus transplantation. You see here that the uterus transplant with your red arrow, that's not the success. First, you have to have the technical success. You have to have established blood flow. You have to establish your immunosuppressive protocols. You're waiting for the first period, who usually pops up 2 to 3 weeks after the transplant. Then you will have to have a successful embryo implantation, go through a whole pregnancy before you have the actual success, which is more than a year later than the transplant. So that's also hard when we give the success numbers, because even if we have done the transplant, it looks great, we might not have the healthy child yet. So it's per definition not a success until we have that. So who can donate the uterus? Well, we can use both living and deceased donors for uterus transplantation. In the US, we have had about 17 deceased donors and 26 living donors. And it's 4 centers that does deceased donors, 2 centers in the US that does living donors, but we see no difference in outcome, and that's important. So whatever we use, we have the same outcome in terms of deliveries and healthy children. So what about immunosuppression? Yes, they need to be on immunosuppression after the transplant. So from the transplant up until the hysterectomy, they are on immunosuppressive regimens. And that's why we want to minimize that time, because we know, and I'm going to show you in some slides later on, what the immunosuppression does to your health as a recipient. And especially what we're concerned about is the kidney health, the renal function with these young patients who are going to live for 50 plus years. We're going to have them with it. We don't want to transplant a kidney on them later on in life just because we destroy their kidney function. So it's important to go through this period of immunosuppression fairly quickly and then take the uterus out. So how is the transplant done? Well, these pictures shows here that we use the uterine arteries on both sides of the uterus, and we use the uterine veins. When we talk about uterine veins, you can see up here, I don't know if you see my pointer, but on your left-hand side, you see a upper, what we call the superior uterine vein that goes in between the uterus and the ovary. And we use the inferior uterine vein, which goes along the uterine artery. We take those arteries and veins all the way out to the internal iliacs, and usually we take the anterior portions of the internal iliac with us with the graft. So in the recipient, we anastomose these vessels to the external iliac. So it's not to the internal iliacs, it's to the external, where you would also, if you were doing a kidney transplant, you would put it to the external iliac. So you can see here we anastomosed one of the superior ones to the external iliac and one of the inferior ones on this side, and then you have the uterine artery that's anastomosed to the external iliac vessel or artery, and then you also anastomose the vagina to the recipient vagina. So this is what it looks like. This picture is actually from Cleveland Clinic. I borrowed it. This is from one of their deceased donor procurements. You can see that on your right-hand side, we have procured the organ and the arrow is pointing to the artery. And since this is a deceased donor, they can use a whole internal iliac up all the way to the common iliac. So you can see the diameter of this vessel, it's actually very big. So this is an impressive, when it comes to uterus transplant, diameter of a vessel. This is what it looks like for us. This is Baylor pictures. So we do now our donor surgeries minimally invasive. The last 10 we have done has been with a robot. We do it as a complete robotic procedure. You can see here the ports where we dissect the ureter on the second picture, where we dissect the superior uterine veins, how we clamp the vessels, and then how we transect the vagina, and then finally how we take the uterus out through the vagina in an endocatch bag. So for the donor, this procedure is way much easier than having an open procedure. These donors go home after 2 days. The evolution of the surgery, in the beginning, these surgeries took a long time. We had 10-hour procedures in the living donors. That's way too long. Now we did one yesterday. It was 5 hours for the donor surgery from skin to skin, which is much more reasonable. So they can go home, you know, after 2 days in hospital. But that comes with experience. So when you start up a new center, you will have, you know, longer surgery times as well. This is the back table preparation. So when you take the uterus out, we assess the organ, and this is very, very important. This is where you have the flush that the other speakers have been talking about through the preservation fluid that goes through the uterus. You get rid of all the blood products in the uterus. You actually assess the vessels. So we never decide whether we want to use the uterus or not until we have assessed the organ on the back table. So it has happened once that we actually discarded a donor uterus, with deceased donor uterus on the back table. We just said, you know, this uterus was great for the donor, but the vessels don't look good when it comes out. So we rather find a new organ for this recipient. And we did. And that organ was much better. And then she delivered. So she was happy with that, even if it was devastating at the time. So the recipient surgery here, you anastomose the vessels. This is one of your uterine veins that goes to the external iliac vein. And then you see the vagina on your third picture here that we're going to anastomose with the cervix as well. This is a short video that I borrowed again from Cleveland Clinic. They do great infographics. This is a uterus coming in, attached to the vagina. You can see the uterine arteries and veins that will be attached to the external iliacs on both sides. So when I look at this as a gynecologist afterwards and do the examination and do all the cervical biopsies, this uterus looks exactly like it would in a native uterus. I can't tell the difference. This is what it looks afterwards. On your left-hand side, you see a Rokitansky patient. It's a patient that's been born without a uterus, but you can see that she has her ovaries and fallopian tubes in place. And your right-hand picture is the same recipient where we have placed the uterus. And you can see that the uterus is here pink. It's vascularized in a good way. This is a case that we actually did yesterday. So that's why, unfortunately, I couldn't attend the conference yesterday. So we did a recipient that was 33 years old with MRKH, born without uterus. The donor was 39-year-old living donor, non-directed. So she didn't know the recipient. She had one child prior to giving her uterus away. And this is where the left-hand picture you can see is the uterus when we flushed it through. We've got rid of all the blood products. This is on the back table where we assess the vessels. You can see the pedicles going out here with the uterine artery and uterine veins. On your top here, you see, on your right-hand side, you see the uterus in place where it's perfused again. So it's looking all pink and nice. On your lower picture here, you can see the two uterine veins. That's the lower one and the upper one going into the internal or external iliac vein. And then you see the artery in the middle going into the external iliac artery. So that's what it looks like. This recipient just woke up. We did a sauna this morning. Everything looks good. And we anticipate her to go home from hospital in 4 days. So why do we then transplant for the infertility? I think it's important to bring this up every time I give a talk. So this is Kayla with her daughter Indy that was born after uterus transplantation. she said that because we're doing this for the patient, and she said she was born without uterus. She said, when you don't have a uterus, you learn at such a young age that it is an option to have a child. It feels like your womanhood was taken away from you. It made me question my role as a woman. It took so much away from me. And a lot of our patients have this experience that they are teenagers when they find out they don't have a uterus, and then the uterus transplant option actually changes their life. So uterine factor infertility is not a rare thing. It's a big deal for many people. This is only showing you numbers from the US. So and also only from women of reproductive age, so in between 20 and 40 years of age in the US. So we have more than 12,000 that's born without uterus. We have 3% of these women undergoing a hysterectomy in the US. We have a couple, less than 1% that has non-functioning uterus. Then you have more than 4,000 that has androgen insensitivity syndrome. So if you add these up, it turns out to be almost 3 million women of reproductive age in the US alone. I'm not saying that all of these women are good candidates for uterus transplant. They might not even want uterus transplant, but even if 1% does, it's a huge group of women that request this surgery. And that is also reflected in the interest we get in these centers in the US. So this is a study that we put out, we published, I think, last year from Cleveland Clinic, UPenn, and Baylor, where I'm at. We looked at the interested recipient that reached out to our institutions from 2015 when we started these programs. And we had more than 5,000 women reaching out to us wanting to have a uterus transplant. And during this time, we only did 39 cases in the whole country. The arrow is pointing at 2021, and you can see that at that year we had 1,300 recipients that wanted to be transplanted, and we only, if you look at the black line, transplanted 2 recipients. So it's a huge discrepancy between the interest groups and what we are actually doing at the moment. So the evolution of uterus transplantation, this picture actually is 2 babies coming from the same mother after a uterus transplant. So this is one of our recipients that had 2 daughters after a uterus transplant. We heard a little bit about the evolution from the former speakers, but I want to go through it quickly. So it started with animal research, and this was in 2000, 2010. And Sweden, Brazil, Japan had a large center was doing this. So I did my PhD in the animal studies. So we were very much doing animal studies in this decade. Then the first human case was done, and you all know that in Jeddah by Dr. Fagay. And unfortunately, that was a case that had thrombosis after 3 months, and they had to remove the uterus. Then it took some time before the Turkish case came in 2011. They were published in 2013. And then that case, a lot of people thought that was a mistake or a failure for a long time, but she actually delivered a baby in 2020. So 9 years out from a transplant, that Turkish woman actually delivered. The proof of concept came with my Swedish group then, when we had the first baby. You saw that picture before, that was born in 2014. After that, we had the second center that was delivered was our Dallas team in 2017. That kid actually made it to the Time magazine cover. And then we had Dr. Wellington's group from Brazil that had the first live birth from deceased donor in 2019 as well. And then the next coming years, a lot of the focus has been to establish this, to get it out of the experimental phase that we heard so much, to get it into clinical care, and we have formed membership requirements for UNOS, which is the organ transplantation here in the US. We have made CPT codes, which is eventually going to be covered for insurance purposes. So there's a lot of administrative things that goes with a new field like this. If you look at the worldwide cases and babies born, we saw this before. So there's been around 100 uterus transplant in the world so far. It's hard to say because there's not really a functioning registry. And I say that there is a registry, but I say that because not all centers are reporting into this registry. And there's a lot of sporadic cases. As we heard before, there's 1 case in 1 institution, 2 cases. So it's very hard to draw any conclusions from these registers that's out there. But we think there's approximately 50 or 60 babies born in the world so far after uterus transplantation. Roughly half of all cases and babies born have been from the US so far. So I will focus the remaining of my talk on more on going into the US numbers and the Baylor numbers. Because I think, I like this quote. It's from Winston Churchill, and no matter what you think about him, but however beautiful the strategy, you should occasionally look at the results. And it's very easy when you have a new field that you are so blinded by doing something new and impressive that you actually forget to look at the results and the outcomes. And that's why we do it. We do it for the patient. So we should definitely always look back and see, are we doing something good? So if we talk about uterus transplant in the US, we have 4 active centers at the moment. So you can see my center, Baylor University down in Texas. You have Cleveland Clinic in Ohio. You have University of Pennsylvania. And the newest kid on the block is University of Alabama in Birmingham. 2 of these centers are currently out of the experimental phase. It's our center in Baylor and the center in Birmingham, Alabama. The other 2 are still under the experimental research trials. We together, all of these centers, formed a consortium because we realized there was no functioning registry worldwide, and we wanted to publish our data in a good way. The first report we did was the first 5 years of uterus transplantation. It was published in JAMA Surgery, and we are now working on a follow-up report of those. So the numbers I will show you coming will be mainly from this report, but also the updated ones. So if we look at the numbers in the US so far, we started in 2016. And you can see that today we have done 44 cases up until yesterday. We had a dip during the pandemic, as anyone else did. We had 2020 and 2021, everything was practically standing still. We still delivered babies, but we didn't do much new transplants, but we're picking up again. So 2023, we have so far done 6 cases, but we have at least 2 more scheduled here at Baylor before the end of the year. So we will get up to 8 or 9 cases, I think, in the US. If you look at the distribution, Baylor, where I'm at, we have done 27 cases up until now. Cleveland Clinic has done 8. UAB, which is Birmingham, Alabama, has done 5, and Penn has done 4. The most of our patients have been born without a uterus. So 95% have the syndrome called MRKH. So they are born without uterus. That was the picture I showed you before, but they have their ovaries and they have their fallopian tubes. 5% have been previous hysterectomies. And those hysterectomies, in our cases, have been due to myomas that they couldn't remove, and they had to remove the whole uterus. In Sweden, when I was there, we also did 1 cervical cancer patient that was diagnosed with cervical cancer when she was a teenager, and 7 years after her diagnosis, we transplanted her uterus, and she actually gave birth to 2 kids after her uterus transplantation. It's interesting, I said that we had the majority of the patients we do are MRKH, so they're born without uterus. But if you look at the interested patients that reach out to our institutions, you actually see that the green arrow is pointing to the MRKH patients, the one that are born without uterus. And you see that that's actually the blue line here. So it's very few, it's 10% of the women that actually contact us that has this diagnosis. Instead, you can see the orange arrow up here, 60% or 70%. Actually, of the patients that contact us that wants to have a uterus transplant are actually previous hysterectomies. And we looked into that. Why did they have their hysterectomies? Well, that was mainly because of postpartum hemorrhage or myoma surgeries, adhesions like Asherman's, or endometriosis, that they had to have their uterus removed. So I think our patient population for uterus transplantation will change as time goes by. When you look at the outcomes, it's important to remember there are many parties to consider when you have a uterus transplantation. This is a picture from a family and their donor and the kid that was born afterwards for Baylor. So you have at least 3 parties to consider. You have the child, you have the recipient, and if you have a living donor, you have to consider the living donor complications as well. And maybe you have 4 parties because you also have a partner, a co-parent, a dad that goes with this couple. So maybe you have 4 parties that you need to consider the outcomes after uterus transplantation. The problem with when we look at the outcomes is also when we did these cases. So the worldwide uterus transplant experience, you can see here that the majority of the cases, the green ones are the United States cases, and the gray ones are the other worldwide cases. You can see that the most of the cases were actually done in 2019, around that area, or from 2016 to 2019. So the actual outcome for these patients, the long-term outcomes, we won't see for another 10 years. So it's gonna, 2026, 2029, that's when we can start seeing the long-term outcomes for these patients. When you look at the outcomes, we talk a lot about mortality. That's very important. We have to have zero tolerance for recipient mortality or living donor mortality. So far, this field has been lucky, and I say lucky because it's surgery, it's big surgery, something's going to happen at some point, but we have had no mortality in either a recipient or a living donor so far, and that goes for the whole world. The second thing is that you look at graft survival or failure. And then we look at the live birth rate. So first, I wanted to define what is a graft failure after uterus transplantation. So this is documents from the OPTM, which is the regulation in the US when it comes to organ donation and transplantation. So we had to make this up because since, as I said in the beginning, this is the first temporary transplantation, we actually meant to take the uterus out after some time. But we decided on that all grafts, all uterine grafts that are removed prior to live birth, that is actually considered a graft failure. So if you have a uterus transplant that looks stellar, it's giving periods, it looks really great, you have great blood flow, but you can't manage to get an embryo to implant, or you can't get her pregnant, or you can't go through a whole pregnancy and deliver, and you have to take the uterus out. That's actually not a graft success, that is a graft failure. So there are two major time points in uterus transplantation where you would have graft failures. The first one is immediately after the uterus transplantation. We call that the surgical failure. And that's where you have the thrombosis, that's the Saudi Arabian case from Jeddah. Those will be technical surgical failures. Then you have the second time point where you can have graft failure is a reproductive failure. We haven't had that at Baylor yet, but we had cases in Sweden where we couldn't get the pregnancy to go all the way. And they have one now at Cleveland Clinic where they're going to remove the uterus. And that's also a graft failure, and that's called reproductive failure. You have a uterus that looks fantastic, but it doesn't produce what you want to. So we start talking about the surgical graft failures. So start looking at on your right-hand side. So this is the US number. So we have had our fair share of graft failures in the US. The majority of those, if you look at 2016, we had almost 70% failing that year. So in the beginning of a field, when you start doing this, you have a lot of learning curve. You have a steep learning curve. So a lot of our failures was in the beginning. So since 2019, we haven't experienced a single graft failure due to surgical issues in the US. So the more cases you do, and this is not rocket science, the better you get, of course. So, but that's something to think about when you set up a center. You should partner with a center that has done this before and then can help you to bypass these early failures. The failures that we have in the beginning are always, in our case in the US, before 14 days. So it's within the 2 first weeks. The median time to graft failure has been 7 days. The leading cause has been thrombosis of the graft artery or vein. But with the right treatment of anticoagulants, with the right anastomosis procedure, you can bypass this and you don't have to have the early failures that we had. When you talk about the reproductive failures, so this graph is to show you the outcome after uterus transplantation in the US. So the blue line is the intention to treat. So this includes all the patients that you have with the failed grafts in the beginning as well. If you only look at the orange line, we have excluded the early graft failures. So this is to test, the orange line is meant to show what happens with the uterus when it survives these 2 weeks. How sure are we to get a pregnancy out of that uterus? So you can see after 5 years of a successful graft implant, you have 90% success rate in pregnancy, which is pretty good numbers if you think about this procedure is actually including IVF as well. And this 90% success rate after IVF, that's pretty good. So the live birth rate we can talk to with our patients. We have here a 2-year cutoff with the green arrow. You can see that if you go past those 2 weeks, you have a 73% chance of delivering a healthy baby within the first 2 years. If we include the other ones, it's about 50% chance of delivering a baby within the first 2 years. So then you can see that this goes up slightly, and we end up around 90 to 100% at 5 years after the uterus transplantation. The majority of our patients, if you look on your right-hand side, so the red circle symbolizes the first birth after uterus transplantation. So this is your first child. The median time is around 14 months after the transfer, or after the transplantation. That's when you deliver your first baby. If the purple line is our second delivery, so the second child of the same recipient, that's usually between 24 to 36 months after the transplantation. So even with these numbers, we can take the uterus out after 3 years, even if you have delivered 2 babies. So again, that's important because of the immunosuppression, and to not hurt these or harm these individuals for the rest of their life. If we look at the complications, this is for recipients and living donors in the US. And this comes from the report I talked about in JAMA surgery. The recipients on your left-hand side, we have a fair amount of infections afterwards. The most common one is UTIs, urinary tract infection. We have had some recipients, 2 in the US, that had a reactivation of CMV. That's important during pregnancy, as you know. We have had a couple during the pandemic that got COVID. Rejection episodes are quite common after uterus transplantation. We monitor this with cervical biopsies. We have never had a graft loss due to a rejection episode, and that's very, very important. So that's why we do these per protocol cervical biopsies. We do them here at Baylor every 1 or 2 months, and that's enough. If we detect a rejection episode, we treat it with increased immunosuppression or an IV corticosteroid cycle, or a worst case scenario. In one case, we have been given an extra thymoglobulin course, but we have never lost a uterus due to rejection. That's important for the patients to know. The very important thing that we have afterwards that actually affects these transplant candidates are vaginal strictures. So I told you we anastomose the vagina of the donor to the vagina of the recipient. And where that anastomosis is, a lot of these patients, up to 70%, gets a vaginal stricture. So many of these patients have to dilate the vagina after the transplant. And sometimes this stricture gets so severe that we have to take them to the OR and just open it up a little bit. And the reason why we want this open is because we want to be able to see the cervix, we need to be able to do the cervical biopsies, and we need to be able to do the embryo transfers. Pregnancy complications, we have had 31 babies born in the US so far. And the most common pregnancy complication we see is gestational hypertension, about 25%. We see gestational diabetes, and we see a few with preeclampsia as well. The last point here, the impaired renal function, that's what has kind of now recently come up, increased to the most thing that we are concerned about. So we are very concerned about these young women, what we put them through in terms of immunosuppression for their lifelong health. So the image, we just published this actually, our kidney outcomes in these patients together with the other US teams. So you can see on your picture here, on your left-hand side on the picture, you see pre-UTX. So that's the estimated GFR before they go into the uterus transplant. Then you can see how the GFR goes through their pregnancy phase, and it's supposed to go down a little bit, and that's fine. And then you can see the green box is symbolizing the postpartum, when we have taken the uterus out and taking off the immunosuppression, and we can see an increase in the GFR during that first year after immunosuppression. But you can see that the last point here is not up to the pre-uterus transplant function. So there is a discrepancy between what they end up 1 year after immunosuppression withdrawal before what they had prior to the transplant itself. So that's something that we are following, and we are very cautious with these young women. When I look at living donors, we have had 20% approximately that had Clavien-Dindo complications. The most common is urethral injury during surgery of the donors. We have also had complications with blood loss, with transfusion. We have had one patient with vaginal cuff dehiscence afterwards, and we have had one case of fecal infection that was so severe that we actually had to take it to surgery to get this resolved. That's very rare though. The most important thing, I think, how are the kids doing after uterus transplantation? And we see a lot of this. So the media is all over this field. So we see a lot of pictures published in the media of these happy smiling parents and the happy smiling babies, but there's no follow-up. So we don't really know how the kids are doing. And the problem is that there's not enough follow-up time. So the first baby in Sweden was born 2014. He's 9. So we don't know what is this going to do to his school time, what is this going to do to his fertility when he comes down that line. We don't know yet. So the most children that was born, you can see here a similar graph to what I showed you before, was between 2019 and 2020, and we can't see the outcomes to at least 10 years afterwards. We have to wait for these outcomes. And the other thing is that we don't have enough publications. So the publications about the kids are sporadic case reports and registry reports. And we try, when we do this first 5 years, to publish a lot about the kids. You have a lot of case reports in this era. But then when we come to 2 years after, so 2-year-old kids, we have only 2 reports. So one comes here from the Dallas group and one from the Swedish group, where you look at some, at least, outcome of these babies. But then from 3 years and up of these kids, there's nothing. And that's very, very important. So what can we expect to see in this population? Well, uterus transplantation is weird because you have an organ transplant, you have immunosuppression, you also have IVF, plus the child is growing inside the transplanted organ. So you have a lot of unknowns in this cohort. So if you compare it to the transplanted kids, or not the transplanted kids, but the transplanted mothers of other organs that give birth after their transplantation, you would be surprised that there's a very, very few publications out there. This one is at least with 43 kids that followed them for a median of 5 years afterwards. You could see that the majority of the things was that they were born prematurely and they were small for gestation when they were born. We do not see that in uterus transplantation. So this is, maybe we can't compare them to kids born after kidney transplant or liver transplant. This is the IVF part. So all of you know that there's a lot of outcome after IVF kids are born, and the short-term health outcomes for children born after IVF is positive. There's some increase in the incidence of cerebral palsy, neurodevelopmental delay, but that's more related to the prematurity and the low birth weight of the IVF kids. So when you look at uterus transplantation, the pregnancy outcomes, why are we concerned? Well, there's a lot of differences with a native uterus. You have ischemia that we put the uterus through during the surgery. We have altered the vasculature. We don't attach it, as I said, to the internal iliacs. We attach the vasculature to the external iliacs, so it's a higher flow system. We have changed the structural support. We only use the round ligaments as support. We don't do anything else to the uterus. We have changed the microbiome with using the donor vagina and the recipient vagina combined. We expose this uterus to rejection and inflammation. We also give immunosuppression through the pregnancy. So there's a lot of things that's different from the native uterus. So how does it look in terms of the pregnancy complications and intrauterine outcomes? Well, this is from the US numbers. So the median age at delivery is 37 weeks. So remember that the prematurity from the other organ transplanted kids, they have a lot of premature babies. We don't have that in uterus transplantation. And you can see here that it's trending upwards too. So we are daring to wait a little bit longer. Here in Dallas, we aim for a delivery at between 36 and 38 weeks. The last 6 deliveries we have done have all been at 38 weeks. So we are now getting closer and closer to a normal delivery afterwards. This is the children, the immediate children outcomes. We have normal fetal development in the US. We have birth weight of almost 3 kilos. So that's a 74th percentile when they come out. Gender has been evenly distributed. The NICU stay have been a median 3 days for these kids, and it also reflects the gestational age at delivery. We have seen no congenital malformations or signs of organ dysfunction. Importantly, we have checked all the female babies that has been born for uteri. So important, because you remember these women were born without uterus, so for them it was very important to see that their kids actually had a uterus, and all of them have a uterus, the kids. We have had no surgical interventions during the first 30 days of life, and you can see on your right-hand side the growth charts, that looks really, really normal. When we look at the longer follow-up, there's only 2 studies that I told you. One is from the Swedish team and one is from our Baylor team. And I'm going to show you just shortly the one that we have for the Dallas team. So this is also published. You can go to BJOG and read it if you want to. So this is updated. We have 18 kids from 16 recipients in this cohort, and we follow them at 6 months, 12 months, 18 months, and 24 months. And we look at the length measurements, we look at the neurological status, we look at the cognitive status, and the physical development. So this is actually our 2 uterus transplant coordinators in this picture, together with a lot of the kids that was born after uterus transplantation. You can see their growth charts on your right-hand side, which are normal. And this is the longer term. So we had one, in terms of malformations, we had one child that had a anteriorly displaced urethra. She had some UTIs, so she underwent a urethral reimplantation at 11 months of age. Does this have to do with the uterus transplant? Likely not, but it's something that we are very interested in following. We had one child that had cryptorchidism, and he underwent an orchiopexy at 26 months, also a normal malformation, but we don't know if it has anything to do with the uterus transplantation. Immune development had been normal, physical development was normal, and we had no neurological aberrations in these kids. It's been interesting to follow the cognitive milestones, because at 6 months, everyone was fine. At 12 months, we had one child, and I'm calling him child A here. He didn't meet his communicative milestone. He wasn't able to use the words in the right way. We followed him when he was 18 months. The same child was referred to an audiologist to see that he was hearing properly. And he also started with an interventional specialist for speaking. 24 months, so when this kid was two years, he still had a delay in his communicative skills, so he went to speech therapy. You can see here it's following 3, 4, 5 years. So this same child at 3 years is not meeting milestones again, and he was then referred to pediatric services, and he was diagnosed with autism. We went back and looked at this particular recipient. There wasn't anything that stood out in her course that could explain this. And she actually was one of the ones that gave birth to 2 kids. So after this child was born, he had a baby sister. That baby sister is developing normally. So we don't know whether this is a normal abbreviation, or if this is a deviation, or if this is something that has to do with the uterus transplantation. So we keep on following these kids up until they reach college level. So I'm just going into my last slide. Sorry for the time delay. So in short, we can say that the uterus transplantation is considered safe for the donor, for the living donor, for the mother and child. The success rate is comparable with most efficient infertility treatments. The success is reproducible, which is important. It's not only in one center, and we can achieve the success with both deceased and living donors. When it comes to the kids, we still know very little about the kids that are born after uterus transplantation. This kid that you see in the picture is the first one that was born in Dallas. He was born in 2017, so he's growing up, but he's still little, so we don't know how these kids are going to do long term. But we need to follow that closely, and we need to be not afraid of publishing our results, because that's the only way we can learn. I want to show you this picture as my last slide, because this is what I consider the real metric of success. This picture was taken at a Mother's Day event in 2022. And you can see us here. This is Juliana Testa in the middle, Bob Gumby, who's our obstetrician, me here, our IVF specialist. And then we have many of our recipients here with their babies that has been born after uterus transplantation. And when you see these women that have struggled with infertility for such a long time, and you are able to meet them afterwards and see, just look them in their eyes when they have their kids. It's a truly amazing experience. So I want to share that moment with you all too. So thank you very much. I'm very open for questions afterwards, whatever you want to know. And thank you again for inviting me. It's been an honor. Thank you.
Thank you very much, Lisa. It's really a pleasure. Dr. Nora, are you available?
Yes, I am here. Just first of all, thank you so much. It's very refreshing, very promising. It makes it look as if it is something that is attainable. So it is very inspiring for all of us in Saudi Arabia. One question, or wondering, I saw one of your patients last night. This is like very unusual coincidence. She had her first baby with you, and she was coming to Johns Hopkins Aramco for a cervical biopsy. And she's very eager to go for the second pregnancy. My question is, the family size in Saudi Arabia is 4 to 5 children. How far would you go with your patient as number of pregnancy if all goes well? Or like there is a time limit and then you would say enough is enough and then we should go for hysterectomy?
That's a very, very good question. And we get that a lot because a lot of people want to have large families, right? So, and they go through all this effort for uterus transplantation, and then you really want to give them the most out of it. So far, we have said that the limitation that we have at Baylor are 3 kids. And that's only because we have, but it comes down to, we want to minimize the time with immunosuppression. That's literally what it comes down to. But also it comes down to the individual patients. So not all patients tolerate the immunosuppression in a good way. So there have been cases after one delivery where we have said, you know, the recipient really wants to go for a second child, but we see that her kidney function is declining, she getting rejection episodes, or then you have to have that very, very difficult conversation with them to make them understand that she, the mother, needs to be there for the child she has for her life. So we can't put her at risk by going through another pregnancy. And those discussions are really, really hard sometimes. But I would say that about 60–70% at least of our recipients would be able to go for a second or a third pregnancy as well. Maybe in the future, and we are looking into now other alternatives to immunosuppressive treatments that's not so toxic on the kidneys. And if we have started using that in 2 patients so far, and if that's going to be available in a larger scale, we might be able to keep the uterus for a longer time. Does that make sense?
Yes, very, very nice. Another question is just like with all these advances, if we are saying that the end or the success point is to have a child out of this uterine transplant, and IVF by definition is not a very successful procedure, do you see it in the future that like you transplant the uterus, you can do also some kind of tubal surgery or reconstruction to make it, to bypass this IVF failure treatment?
Absolutely. So we have been thinking about that too. The reason why we haven't done it so far is that in the beginning, when they started looking at uterus transplant, they actually started transplanting the tubes, right? And the tubes are very delicate structures, so they don't withstand ischemia as good as a solid organ would. So there's that. So we don't know how the tubes would actually function afterwards. And then there's the other thing, you know, if you let them spontaneously get pregnant, you might have to wait for a very, very long time before you have the actual pregnancy, because that's in every couple. So we have chosen to do IVF just because then we can control when we get them pregnant, and so we get within this time limit. But I'm sure that in the future we will see, and especially if we find drugs that allows us to keep the uterus for a longer time, that we can also do natural pregnancies. One difference with the IVF from a regular population than this population is that we select, at least at our center, we select proven uteri. So only uteri that has been used before and has delivered before. So we don't want to transplant a uterus that hasn't proved to work, and then you will bypass all the uterine factor infertilities that you can actually have in that uterus. We actually have higher success rate after uterus transplant regarding the IVF than you would have in the general population.
Interesting. Yes, I noted that 90% that is not achievable in
I know,
IVF.
I know.
Yes,
but that's very true.
Yes.
Yeah.
Thank you so much.
But it's not fair because we only use the proven uterus, so we can't compare.
Of course, of course. Yes. Yes. Thank you so much. Very interesting.
Dr. Rubalcaba, you have comment?
Yes, thank you very much, Lisa. Thank you so much. First of all, congratulations for your very nice talk, also for your success in Duet's program. Just wondering, short question. Most of the patients have had preeclampsia, also hypertension. Do you think that this cause is regarding the Rokitansky syndrome with one kidney, the immunosuppression, or trying to do hormonal replacement to do SET, single embryo transfer, in absence of corpus luteum? As a fertility doctor, we know that if we prepare the patient with hormonal replacement, we avoid the corpus luteum. Corpus luteum is so important to avoid the preeclampsia. What do you think about that?
So, I mean, this is a very, very good question. And I can honestly say that we don't really know, because we have all these different factors, right? We have the immunosuppression, and we see a lot of preeclampsia after, you know, kidney and liver transplants as well. So we know that the immunosuppression has one part of it. And then, as you mentioned, after the IVF can also give higher rates of preeclampsia. And then we have the transplanted uterus, and we don't know what that is. And then you have the MRKH patients who are sometimes have kidney malformations and a single kidney, as you said, which is a higher exposure to preeclampsia as well. I can say that all of the preeclampsia cases we have seen have not only been in the ones with MRKH. So we have seen preeclampsia also in one patient where we had a prior myomectomy, so previous hysterectomy. But I think all of these might go together. We are very careful now to include single kidney patients in our trials. And I know that a lot of the other US centers are also careful with this. And if you do, you have to keep the tacrolimus levels down a lot. I was looking at what they presented, Dr. Wellington presented from Brazil before about the tacrolimus levels. And he said that they kept them on 8 to 10 in tacrolimus levels. We have much lower doses in our patients to minimize the kidney toxic effects, and that also minimizes the risk of preeclampsia. So that's something you have to weigh the risks and benefit with all different things. But I think you're right, there's multifactorial issues why this might be ending up in preeclampsia.
Thank you so much.
Thank you. Can I ask a question, Dr. Harbi? Now we know with the pregnancy that the cortisone level usually endogenously will go high 3 to 4 level, and the patient is still in immunosuppression. Did you put this in consideration? If the physiological changes in pregnancy usually make the cortisone level high in the body, do you try to taper or decrease the immunosuppressants?
So
or the other
yes,
question is who is taking care of immunomedication and the nephrotoxic drug? Is the gynecologist or another consultation?
Yes, so those are excellent questions, both of them. So we have our patients on a dual therapy. So we have them on tacrolimus, which is a CNI, and we have them on azathioprine. And the reason why we have we don't use corticosteroids at our center at all. So the reason why we have them on 2 different drugs is that in doing that, we can kind of spread the blame a little bit. So we can decrease both of the doses of these 2 medications to not have too high of either or. So that helps us. And during pregnancy, we have very few, only the first 3 months, we keep them fairly high in immunosuppression, and then we decrease all the time. And during pregnancy, we have not at all seeing rejection in the same way as we do otherwise. So we keep them on almost nothing during pregnancy. So we're not, and the second question is who's monitoring this? Well, we have a very particular team here because I've been working with this for a very long time, and I partner very closely with Giuliano Testa. I come from the gynecology world, he comes from the transplant world. So it's us 2 that monitors the immunosuppression. But it depends on your center, I would say. So if you have a center that's more, we have a very unique situation here where we have this close collaboration. If you have a center where the transplant surgeons are very used to taking care of the immunosuppression, they should do it. So go with what your center is good at. That's my recommendation. You need to have a collaboration, but don't go outside the box too much. Use your regular kind of gateways that you have, so if someone is normally taking care of immunosuppression, use that person.
Thank you.
Doctor, one more question. In between pregnancies, you are doing a cervical biopsy to detect rejection, right? Do you still do that during pregnancy itself? Do you take cervical biopsies?
Yes, so we do. So in the beginning, so we start getting them pregnant 4 months after their transfer or their transplantation. So during those first 3 months after the transplantation, we do monthly biopsies. So once a month, I do a cervical biopsy, we send it for pathology. And then when they get pregnant, after 3 to 4 months, we do 2 biopsies during the pregnancy. So one at around in the end of the first trimester, so around 12 to 14 weeks, and then one other biopsy in the end of the second trimester. And that's only to kind of monitor the organ throughout the pregnancy. In saying that, though, we haven't seen so many rejection episodes, so that might be over the top a little bit, but we still want to make sure that the baby's doing fine. So we do those 2 biopsies. And then when she has her delivery, we go back to the monthly biopsies. And then when she gets pregnant again, we do 2 biopsies during the pregnancy.
Excellent. Do you see it in the near future that there will be like subspecialty and people will be coming training rather than starting a unit in various, locations in the world?
You know, I think so. We have, every time we do a case here, we have international teams or national teams here that wants to observe the cases. And we also go out to a lot of the centers around the world to help them with their first cases and help them to build up their centers. Me personally, I think it's important that we are there as support. We can be scrubbed in, we can help with the surgery, but we don't take over the surgery. So we think it's very important that they do their cases, you know, with us as support. And when they're here, we try to, you know, teach them as much as we can. Whether this is going to be a fellowship or, you know, a subspecialty, it's hard to say because it's a very combined area. So you have gynecologists, you have REI people, you have transplant surgeons, you have pathologists. So it's a lot of different occupations that goes into this. So I don't know who would be the perfect, you know, subspecialist in this. If it would be one from the gynecology part or one from the transplant part.
For the time being, is it covered by insurance in USA?
No, it's not. So our first 20 cases we did at Baylor, we got funded by our institution, so they paid for it. And after that, we have set the price on it. So our patients actually pay for it themselves. That is not how we want this to work because it excludes a lot of patients. But to keep the flow going and to keep the amount of cases, we needed to do something. In the meantime, we are working with the insurance companies to get them to cover at least parts of the procedure. So they can cover the pregnancy care, they can cover the immunosuppression, and then eventually, hopefully, we can get them to cover more of the surgery itself as well.
Thank you so much.
Any question from the participants or the attendants? It is really a privilege, Dr. Biza, Dr. Rubalcaba, and Dr. Wellington, Dr. Nora also, Dr. Nasser being with us today, supporting.
Dr. Mohammed, I think there is one question in the Q&A.
Okay.
Or 2 questions, maybe.
This is for you, Dr. Nora. Can you?
Yeah, one question, Doctor. This is regarding, have you noticed any increase in the incidence of abnormal placentation like accreta or brevia?
Yes, so we have had one patient with accreta of our patients. And it's hard to know why that is. We know that IVF, of course, has a little bit higher accreta. And also that particular patient, her donor had 2 previous C-sections. So that also increases the risk of accreta. But we don't see it in a higher, you know, than that. So we had 1 out of the 18 babies that was born was accreta.
Yeah. So maybe include this in the exclusion of donors. They should have delivered vaginally.
Maybe, but
the question again,
a lot of people.
The question again.
The question
So the
Why-
question,
Why not one baby and hysterectomy?
oh yes. You mean for our patients, why not settle on one baby and then take the uterus out?
Yes, because most of the centers settle in one baby, but you are outside the box thinker, which is we like in Saudi Arabia to have more children. So now, if I think of two pregnancy, I can say, okay, good. I can spend $300,000 for two babies, but for one baby, it's too much. Maybe that
Yeah.
make it feasible, but we have to convince them two and more, maybe possible. But why
Yeah.
you decided to give more than one child? Because I'm sure at the beginning of the program it was one, then something happened and said, okay, we can give them another chance.
So actually, in the beginning of the program, we had 1 to 2 kids. That's what our IRB approval said. So we were, but some of them only want one child. So that's the first one. You know, you have to listen to the parents. And then the other thing is that some of them are not able to have. So we look at every individual case. So the first thing is, of course, you know, do they want a second child? The second thing is, are they able to have a second child from medical issues? So we have to look at the kidney function. We have to look at the time limit. When did they deliver their first one? Was that 1 year out from the transplant, or was it 3 years out from the transplantation? Was this a problematic course? Then we might say no to a second one. So, but we always allow them to discuss the option of a second child, for sure. And I think that's important because they go through a lot with this first, you know, with this uterus transplant and everything. So you should always take that into consideration. But there are patients where I would say no, even if they want to.
Any other questions from the audience?
I think Dr. Rubal Kaba is raising the hand.
Rafal Kaba?
Yes.
Do you have a question? You are mute.
No more questions. Everything is so clear. Thank you so much. Congratulations for your symposium. And I am so grateful with the kind invitation. Thank you so much.
I think at the end, Dr. Noura, Dr. Lisa, Dr. Rafal Kaba, we will do some sort of report, like a consensus. And maybe Dr. Noura, because she's a member of the scientific committee, a scientific board, I mean, of the Saudi board for health specialties for obstetric gynecology. So maybe this is just an introduction, or just, I would say, a guideline that the scientific board of the Saudi Commission would be able to start with, and to make future health or future the future would be more clear for our friends from the gynecology and obstetric. So I think this meeting is important. So everybody would be able, what are the limitations, what are the obstacles, and also the ethical part in our country when it's going to be completely legal. I hope so, Dr. Noura. And your presence here was with our colleagues from different parts of the world was quite significant and important to discuss this issue in the Middle East in a formal manner, and in a well-established structured program, so people will have good health care regarding primary infertility in the future.
Thank you so much, Dr. Mohammed, for the invitation. It is a very important issue to be discussed and to push for it forward. Maybe people from other parts of the world, they don't know that it is illegal for us here to have, for surrogacy and for adoption. So the way forward for patients who are not able to have children, maybe the uterine transplant, and we are hoping, inshallah, very soon that it will be legal in Saudi Arabia. Thank you, Dr. Mohammed. It was a pleasure being with you all.
A quick question after the last question. I know it's not nice. How much the American cost each patient you spend in the patient averagely?
Yeah, so there's a difference between cost and charges, right? So that's very important in the US. So, but what we did was that after we had the first cases, 20 cases, we sat down with the financial department and we looked at all the cost we have spent. What did the 10 patients that was most straightforward, how much did they cost? And that included the surgery, it included the pregnancy care, all the immunosuppression, the hysterectomy, all of that. So from point A to the exit point. And the donor surgery as well. So if you look at only the cost, that will be around $250,000, but that includes all of it. So parts of that, and that will be different even in different American institutions, and it will definitely be different in different cultural and countries. But that's, and we can share those numbers with you if you guys want to as well, when you are starting to build up your own centers. But for our patients that now approaches us, they have to pay 295,000 American dollars for everything up until the delivery of the first child. And then if they want to go for a second child, they will add, I think, $80,000 more. So that's a lot of money. And we have a lot of patients that's fundraising or having organizations that stands behind them to be able to afford this. Hopefully, as time goes by, the more cases we do, the cost will also go down.
Thank you, Dr. Harman. Thank you, Doc.
Thank you so much. It seems to be a large sum of money, but you cannot put a price tag on bringing life. So it's worth it.
Yeah, I think you're very right there when you say that. And also, here, surrogacy and adoption are legal in the US. And if you compare the cost of uterus transplant to the surrogacy cost, it's actually not that big of a difference. So even if it's, it sounds like astronomical numbers, that is all the same cost as other alternatives would be.
Yes. Thank you.
So I think we are coming to the end of our meeting. We will hopefully in the coming few days or few weeks, we'll send like a summary. Also, the recording will be available for whoever is willing to listen again. Hopefully we can, Dr. Noura, make a summary, as I told you, or a consensus with the collaboration of our international speakers. And hopefully this can support future progression with, of course, the governmental and the legal and the ethical parts in our country. Hopefully the future progression will be more precise, more controlled, and more successful.
Thank you so much.
Thank you very much, everybody. And see you again.
See you. Bye.
Goodbye.